Assalamu alaikum. Inshallah, today we will talk about upper cervical injuries, part 1. Usually, all spine region in which between the cervical and thoracic and between the thoracic and lumbar, between the lumbar and lumbosacral is the area of junction between relative mobile and relative immobile segment. So the susceptibility for the upper cervical is due to the relative immobile cervical head region, cranium, and relative mobility of the subaxial spine. As I inform you in the cervical anatomy lecture, stability depends mainly in the upper cervical region upon ligamentous structure, not upon congruency, mainly on ligamentous structure. We have 6 injuries in the upper cervical region. Today, inshallah, we will take occipital condyle, craniocervical dissociation, and atlas fracture. Occipital condyle. Anderson classification has 3 types. Either comminution, and this is stable, so mostly treated conservatively. Type 2 is extended to the base of the skull, so usually we transfer this type for neurosurgeon. Type 3 is avulsion, mostly well associated with ligamentous injury and causing type of craniocervical dissociation. So managed mainly according to the next session about craniocervical dissociation. So this is comminuted type 1, usually conservative. This is extended to the base of the skull, and this is avulsion type, most unstable. Non-operative management for all upper cervical injury. Mostly we will manage upper cervical injury with conservative management, except some injuries. The types of non-operative management, either Miami J collar, or of course for stable injuries without neurology, all the cervical region. Keywords to detect whether we will manage this patient operatively or non-operatively according to stability and neurological injury. So stable injury and neurological injury detect our management. Mostly all cervical region, upper cervical region is a stable injuries, and because of wide canal, mostly they willing to have a neurological injury. So mostly they will be managed conservatively. The methods of conservative management is either Miami G collar or what is called halo vest. Actually, halo vest is a method we use when I am not sure about stability. If I suspect some sort of instability, but I don't want to manage him operatively for any reason. So halo vest, this is the vest, and this is the halo. Halo, this is the ring with 2 pins anterior and 2 pins posteriorly, 4 bars, vertical bars connected to the vest anteriorly and posteriorly. The pins anteriorly should be laterally to avoid supratrochlear and supraorbital nerves, and not lateral so much to avoid temporalis muscle. and should be below the equator of the skull. Below the equator of the skull. The posterior one is generally placed above the external occipital, external auditory meatus, below the equator of the skull. When you tight in adult, we use a torque limiting about 8 inch, adjusted to 8 inch. The position of halo, the head can be slightly managed inside this ring, either in extension or flexion, to reduce what I see is unstable. So I can do some extension moment or flexion moment to head and adjust it inside the ring in relation to the vest to make some type of alignment. And this is one of the advantage over the ordinary orthosis. Usually we re-tight again this pins in the second day. We use it for upper cervical only, occipital condyle, C1, C2, not for the lower cervical because of what is called snacking phenomena. Snacking is an abnormal rotation between upper and lower cervical spine. Usually the upper part of the cervical spine have an excessive extension and the lower one excessive flexion. So an excessive rotation occur between both parts, and this impede healing. For example, as we will see later, some type of occipital condyle as occipital condyle C1 and C2. Some part which stability can't be confirmed. One of its advantage is manipulation, and you will do x-ray, then adjust again, and so on. Again, indication for surgery is to detect instability and neurology. If you have neurology, sure, you have to decompress, and when you decompress, you can take a lot of bone, so you, even if he is stable, you will convert him to unstable, so you will fix or fuse, or already has instability. As I inform you, all upper cervical is conservative. Some special situation leads to instability, especially type 2 occipital condyle, in which could be associated with craniocervical, and we will manage it in the next lecture. Of course, if it is unstable or neurology, so you will decompress, you will fix the cranium, the head, to the cervical spine. In the cervical lecture anatomy, we put the screw in the sixth part of the cranium around the external occipital protuberance. Next lecture is craniocervical dissociation. Craniocervical dissociation, the same as atlantoaxial dissociation, could be traumatic or acquired. Traumatic or acquired. Acquired mostly for us is rheumatoid or Down disease, Down syndrome. Just review for the cervical anatomy of the ligaments, because they are the main stabilizer for the cervical region. Here posteriorly and here anteriorly. Posterior was there is a 3 ligaments, occipital, atlantal, posterior ligament, and atlantoaxial posterior ligament. This is are deep, and superficially are nuchal ligament. Anterior there is the from dorsal to ventral. Dorsally is the tectorial membrane, then continued as posterior longitudinal ligament, then transverse atlantal ligament, which is posterior to odontoid, and this is the transverse part of cruciate ligament. Has a vertical and inferior limb, and transverse, which is the most important, transverse atlantal ligament. And odontoid ligaments, apical and alar ligaments. And anteriorly is anterior atlanto-occipital, which continued as anterior longitudinal ligament. Tectorial as a posterior longitudinal ligament, and anterior atlanto-occipital as anterior longitudinal ligament. This is the main stabilizer. So if you suspect an injury here and you did CT and MRI and found signal change in this ligamentous part, so some sort of instability is here, which is rare. Cranio-cervical dissociation can be classified according to less important classification according to direction of the head in relation to the neck. Could be anterior, posterior, or distraction type. And this is actually detected by what is called Bowers ratio, which is have very poor and low sensitivity. Actually, craniocervical dissociation is a fatal injury, especially if it is traumatic. Usually you didn't see him, but if acquired, you will see him, either in rheumatoid or, for example, down. What is Bowers ratio? Only for purpose of exam. This is the foramen magnum. This is the base of the skull, foramen magnum. Its anterior part is basion, and posterior part is opisthion. This is the anterior arch of C1, and this is posterior arch of C2. By dividing this on this should be 1. If more than 1, it is anterior. If less than 1, it is posterior. I inform you before, I want to detect stability and neurology to detect and determine my operative management. This classification couldn't detect stability. So just for exam, I inform you about this. The more important is Harborview classification, which detects stability. Stability is detected by this space. If this space is more than 2 millimeter, this is unstable injury. If less than 2 millimeter, it is stable injury. This is the occipital condyle, and this is C1, and this is the space in between. Again, you have a cervical injury, so you did CT and MRI, and you found some ligamentous injury here or there. You will do, already you did lateral X-ray. This is lateral X-ray during supine position. It's called the static X-ray. If you do a traction, controlled traction to the skull, and repeat again, this is a stressed lateral X-ray. As usual, for all ligamentous injury, you have to stress. Harborview, you did MRI, Harborview classification, you did MRI and you found signal. If a static X-ray is less than 2 and traction view is less than 2, this is stable injury and this is type 1. If static X-ray is 2 millimeter but traction view is more than 2 millimeter, this is type 2. If just the static X-ray is more than 2 millimeter, This is a unstable injury, and sure you willing stress more. Type 2 and type 3 need management, operative management. For sure type 1 is conservative. Indication of surgery, again, stability and neurology. Stability here is more than 12 millimeter. Atlas fracture. This is the anterior arch of the atlas. This is odontoid. This is the tubercle in which the transverse atlantal ligament attach, and this is the posterior arch. Fracture could be here or there or in between in the lateral mass. This is the lateral mass, area between superior articular process and the inferior articular process. Again, instability is detected not by bony, more by ligamentous disruption. The main ligament in atlas fracture is transverse atlantal ligament. So to detect stability, I need to know if this ligament is intact or not intact. Detection of intact ligament, transverse atlantal ligament, is intact or not can be either by direct or indirect means. Direct mean is to detect avulsion of its attachment in the CT or by MRI signal. This is direct means. Indirect means is this is the occipital condyle. This is the lateral mass of C1 and this is lateral mass of C2. If the space between the lateral part of the lateral mass and lateral part of the lateral mass of C1 and C2 on both sides is more than 7 millimeter, this is called lateral mass overhang and could indicate instability. The atlantal ligament should be from here to there. So if there is disruption here, this mass will be displaced laterally in relation to the lateral mass below it. And if this summation of both sides is more than 7 millimeters, this is a indication of instability. This is AB view, odontoid. This is odontoid view, coronal view. You can detect this in either an open X-ray, open mouth X-ray, or on coronal CT. This is axial CT with avulsion, anterior arch fracture with avulsion of the lateral side attachment of the transverse atlantal ligament. Another example, avulsion of its insertion on the tubercle on the lateral mass, open mouth more than 7 millimeter. Another sign of instability is this is the dens and this is the anterior arch. Between the space, this space is anterior atlanto-dental interval. This space is very important because posterior is posterior atlanto-dental interval. Anteriorly, this space should be less than 3 millimeter and up to 5 in children. If more than 3 millimeter, it could suspect that there is a fracture here or the transverse atlantal ligament injury there. Could cause this space to be widened. Again, most of upper cervical injury managed conservatively with Miami G collar, not a soft collar. Don't put a soft collar at all. Miami G collar or hollow vest. If in doubt about stability, you can do hollow vest. Indication for surgery, again, instability and neurology. Instability here in atlas fracture depends on transverse atlantal ligament injury, either detected by direct or indirect means, and anterior atlantodental interval. Okay, how to fix? What is the options we have? If you have, this is C1 and this is C2. If you have a fracture here or unstable here, and you can put a screw through the lateral articular process on both sides by one screw here and one screw there, and there is no obstacles related to vertebral artery, this is called a C1, C2 transarticular on both sides, one screw on both sides. Very stable and very cheap. Or you can do what is called segmental fixation. This is C1 and this is C2. If you put here lateral mass and there pedicle or bar, please review the cervical lecture anatomy. Here lateral mass, or here bars or screw or pedicle screw, and connected both by rods. This is called segmental fixation between C1 and C2. Lateral mass C1, pedicle or bar C2. Again, review of cervical lecture anatomy. If you reach by your screw here, this is pedicle screw. If you there, this is a bar screw. If you didn't reach the pedicle, this is a bar screw. This is a bar screw. Another type of fixation which is weak is wiring fixation. Wiring fixation through prox or galley. Prox fixation by two bone blocks on the either side, and galley is one bone block fashioned around the spinous process. This is galley method. Thank you so much.